basically it's one and the same thing. Opioid OST or opioid substitution treatment. It goes by a wide variety of names. It goes by a name of agonist maintenance treatment, agonist substitution treatment by using buprenorphine or methadone or so on. And Americans in particular love the last name, MAT, medication assisted treatment, because they believe the treatment is much more than giving just medicines, hence medication assisted treatment. Somehow American government in particular has not been too kindly for this approach of treatment. So we have discussed very briefly what opioids are in the morning. We know the opium cultivation in India, how heroin, brown sugar or white sugar are extracted out of it. We know that it can be chased or injected. And then there are some agonists, partial agonists and antagonists. We have been talking since morning about this. For lay people from a non-medical background. What are agonists? Agonists act like duplicate keys. Like every lock is supposed to be opened by a key, but locks can also be opened by the duplicate keys. So the lock of the brain, which is usually opened by heroin or morphine, can also be opened by drugs which look similar to them, which act similar to them, and hence those drugs are known as agonists on that particular receptor. Suppose this is the opioid receptor in the brain, the site of action of opioids, and you have here opium or morphine. You can see that the triangular protrusion fits very well into this lock, and hence it can give rise to intoxication or the effects of opioids. But if you have another drug like heroin, which also has that same triangular thing, it can also fit into the lock and also can exert the similar effects. So it's the agonist. We can say the heroin is agonist at the opioid receptors, morphine receptors. Buprenorphine, it doesn't fit that lock as well as others do, and hence it acts only as a partial agonist, which means its effects are only partial. It's not as intoxicating as other opioids do. Sometimes we also insert a wrong kind of key in the lock when we are trying various keys, and then we find कि चाबी जाके फंस गया ताले में, और असली चाबी मिल भी जाती है तो भी ताला नहीं खुलता, क्योंकि ताले में गलत चाबी फंसी हुई है. So that's what happened with the antagonists. They do not have any action of their own. They just block the receptor. They just block the particular site of action of opioids. So when the site of action of opioids is blocked, even if you get the agonist drugs like opium, heroin or buprenorphine, they won't be able to exert their effects. So this is how agonists or antagonists work. And that's the principle behind using this particular form of treatment. Now there are various kinds of opioid agonists available. Some of them are natural derivatives like opium, morphine, codeine. Some of them are semi-synthetic, some of them are purely synthetic. In fact, buprenorphine is also being called as semi-synthetic in some classifications. And many of these can be or are injected in the country. Morphine, of course, is an injectable. Heroin can be injected. Pentazocine, very popular drug for injectors. Injection Fortwin is the brand. Buprenorphine can be injected. It's the injectable version. And interestingly, we remain probably the only country in the world where this also is injected, dextropropoxyphene. Particularly in Northeast, Manipur, Nagaland, Mizoram, people used to open the capsules, take the powder out, mix it in some liquid and then inject it. That was a common practice in those states, though that's not seen so frequently in other states of the country. So a wide variety of opioids are available which can be injected. We have seen the acute effects of opioids in the morning also, how pleasurable, how intoxicating, how reinforcing use of opioids can be. We have also seen in Rao's presentation opioid withdrawal symptoms. The acute withdrawal symptoms which last from hours to days, which are distressing enough. But the problem is not just these. Problem is also the protracted withdrawal symptoms. Even after you treat someone's opioid withdrawals by a detoxification method within a period of 10 to 15 days or up to a month, for next 6 months the person is going to experience these distressing symptoms. And taken in total, a person's life who is experiencing dysphoria, who is experiencing premature ejaculation, pains and aches, difficulty in sleep, it's quite a distressing experience to go through for many months altogether. And coupled this with the previous life of addiction, where 3 or 4 times a day he used to get a high, he used to get a pleasure. Imagine the vacuum which has been caused in that person's life. So no wonder that most opioid dependent individuals would tend to relapse very soon just if you treat them just by detoxification, where the most very important reason is these protracted withdrawals. In other words, drug dependence should be seen as a chronic relapsing disorder like diabetes, like hypertension. In fact, McClellan et al. In USA conducted a very good review of outcome of short-term treatment of various medical conditions together. So they compared asthma with diabetes, with blood pressure, with drug addiction. And they found that relapse rates at the end of 1 year were almost similar. So this is an answer to all our physician colleagues who keep telling us, या तुम किसका इलाज करते हो, ठीक भी तो होते नहीं है तुम्हारे पेशेंट. उनको बोलो तुम भी तुम्हारे ब्लड प्रेशर के पेशेंट को 15 दिन का दवाई दो और उसके बाद कोई ट्रीटमेंट मत करो. And measure their BP 1 year down the line. देखो क्या होता है, right? So this is an illness which requires long-term treatment. This is not an illness which can be helped by a short-term course of treatment. So the treatment of opioid dependence, it involves these steps: assessment, detox, and then a long-term treatment for which we have these two approaches: an agonist maintenance or an antagonist. Let's talk about the agonist maintenance treatment approach first. Detoxification, very succinctly described by Dr. Rao. We know that it's short-term, gives people good relief, but it is associated with a very high rate of relapse. Hence, we need to think about agonist substitution or long-term treatment with agonists. And what's the philosophy here? Person who is taking a drug like this. What kind of drug is heroin? It's illegal, medically unsafe, short-acting. This is the most important aspect. It's short-acting drug, hence he has to take it 3 or 4 times a day. It's taken by a serious route, taken by a dangerous route, injecting route. You simply substitute this drug at the receptor level with another medication like buprenorphine, which is what? It's legal, it's safe, it's long-acting. So person has to take only once a day, and there is chutti for the entire day. It's of known purity and potency, you know what it contains, and also you give it under medical supervision along with psychosocial interventions. So in effect, the person is on an opioid, but earlier he was on illegal, unsafe, dangerous opioid. Now you are giving him a medicine which is also an opioid, but which is long-acting, safe, under your own supervision. The principle is not very different from the situation when the mother takes a small child out and the child keeps asking for junk food. वो chips का packet दे दो, कुरकुरे दे दो. And when do children ask these things more? When they are hungry. So the smart mother ensures कि जाने से पहले घर में बच्चे ने घर पे बढ़िया दाल रोटी खा लिया है, बच्चा will not ask for these things. And even if the बच्चा asks for chips or kurkure, if the stomach is full, बच्चा will not be able to finish that packet of chips or kurkure because there is no space in the tummy. So if you give someone buprenorphine early in the morning, which is a long-acting opioid agonist with good receptor affinity, all the receptors are already occupied. Even if the person develops craving for taking heroin during the course of the day and he tries taking heroin, he will not have any experience, he will not have any influence because all the receptors are already occupied by buprenorphine. That's the philosophy, that you saturate someone's opioid receptor by using a long-acting, safe, legal opioid agonist medication, which has a higher affinity for receptors. So what kind of medications are suitable for this kind of treatment? So this is our principle. The medication should have these characteristics. एक तो उसको withdrawal symptom ठीक होने चाहिए. It should also address the craving, the desire to take drugs. It should have easy to administer. It should be safe and easy, and have minimum side effects of its own. Should be economical, and this is the most important part. It needs to be long-acting. Person was taking illegal drugs 3 or 4 times a day. If your medicine also has to be taken 3 or 4 times a day, he cannot be productive. The idea is that you give him a medicine which he has to take just once in a day, and then he is free throughout the day to engage in productive work, to look after his family, to become a productive citizen of the country once again. So that's the idea behind using these medicines, and these are the medications which have been found suitable, used world over for agonist maintenance or opioid substitution treatment. Methadone, the oldest of these and perhaps most well researched medicines, not just among these, in general among all medications, probably methadone is one of the most well researched. Why? Because it has been controversial. So every country before deciding methadone in it says हमारे यहाँ भी एक research करो, एक और research करो. So there are lots of huge amount of research evidence behind effectiveness of methadone. Buprenorphine also is going through the same thing. It's also now very well established. Our country, the trend has been different. We have been using buprenorphine for a very long time. Methadone has been introduced only very recently. And most important thing, the last, opium. Opium itself shares many of the characteristics of a good agonist maintenance agent. It's long acting. You take it orally in a very safe route. It also not very deeply intoxicating, so it gives rise, controls just some withdrawal symptoms and doesn't make you dysfunctional. The only problem is its legality. There was a time when opium was available in India to registered addicts. We in our country, from the British time onwards, we used to have a system of opium registry.